Welcome, students. This is Dr. Tom Wadsworth, and we're here on part 2 of the Intro to Pharmacist Billing and Reimbursement lectures. And we have with us again Dr. Andrew Hibbard and Dr. Zach Roscoe. And I will turn it over to them to go over the objectives. This is a 2-hour lecture, and we will make the handouts available. We encourage you to print the handouts off and follow along as you go. The exam questions will come off of this lecture as well as the first lecture. And you do need to have listened to the first lecture in order to listen to this second lecture. And with that, I'll hand it over to Dr. Hibbard and Dr. Roscoe.
Thank you, Tom. For today's lecture, we want to first go over the objectives. Today, we want you to be able to recognize and explain the required components for coding and submitting a medical claim. We want you to be able to define the CPT and HCPC codes, specifically MTM and Evaluation and Management Service codes, and identify when each of those should be used. Want to have you be able, when you're given a case, to identify the appropriate CPT or HCPC code to select, specifically focusing on the MTM and E&M codes to submit for reimbursement, and then place the steps of medical billing and coding in the correct order. We're going to start off the first hour here with the components for coding and claim submission. And this right here is what we want you to go back to when you're looking at the overall process of reporting healthcare services provided. And this is when you were billing a medical benefit. And we're going to start off with the place of service, which is where the service happened, because this actually defines both the code sets that you're using and, in many cases, will define the amount of reimbursement you're going to get. So this, when we say place of service, this is not the same as point of sale, but this is where the service itself was rendered. And this often changes the reimbursement or the RVUs, which is a calculation of the amount of work performed done for a given service. And there are common coding place of service codes that are maintained and created by AMA and published in the CPT manual annually. What we have here are a list of some of the common codes you would see as a pharmacist clinician. And curiously, the actual first code in there is pharmacy as a place of service. So this would designate when a medical claim is coming out or being rendered at a pharmacy, whether that's a standalone pharmacy or a pharmacy within another facility that is maintained in its own walls and has its own separate area. We have a code for outpatient hospital billing. So this would be components of a hospital system that are attached and maintained by the hospital, but not internal to the hospital itself. There are codes for walk-in and retail health clinics, rural health clinics, public health clinics, and federally qualified health centers. And these are all important, again, because one, it can define what you get reimbursed, but it also, in many cases, determines what code sets you're able to choose from. The next component, once you have determined where this happened, you want to move on to defining what you did. And for that, we're looking at the CPT or the HCPC codes, commonly referred to as the HCPC codes. Now, HCPC or HCPC stands for the Healthcare Common Procedure Coding System, and this was actually established with the HIPAA laws. And this is a standardized coding set that is maintained by CMS that allows medical practitioners to consistently define the services that are provided. And these are actually broken down into 3 different categories of codes. The first set, the category 1 codes, are the CPT procedure codes. And this is where we're going to see numeric codes such as 99201 through 99215, which we'll get into a little bit later and are referred to as evaluation and management service codes. And this is also where the MTM service codes 99605 through 99607 live. Category 2 codes can be identified based on the fact that they're alphanumeric, and these are G codes. So they'll start with a letter and followed by a number of numeric characters. And these a lot of times refer to bundled services, and specifically some of the G codes that you would see are actually selected based on the site of service. So whereas in a pharmacy or an outpatient clinic, you may select a CPT code in category 1, if you are in a federally qualified health center, depending upon the payer, we would generally be selecting a category 2 CPT code, a G code, to have a bundled reimbursement for services provided by a federally qualified health center. CPT codes stand for current procedural terminology codes, and these are just another type of code that defines the type of service. This describes the patient encounter in terms of complexity of the work performed by the performing provider, and it may also describe a laboratory. It describe a specific drug reagent used in a test as well. Now, each code is very specific in what it's defining as the work being performed, and each code may have specific restrictions on who can use the code. And that is built into the definition of the code itself. And the code definitions, including what is contained within that code, is all maintained by AMA, and CMS, the Centers for Medicare and Medicaid Services, by rule, uses AMA's definitions. Just to note that those definitions are published annually in the annual AMA CPT manual. So medical coding and billing itself, when we are submitting a specific CPT code for reimbursement, we call that fee-for-service reimbursement. And again, this is just reiterating that the Category 1 CPT codes are submitted for a specific service being provided, and they are linked with a diagnosis and code a level of complexity for that visit, and the diagnosis attached to that defines the medical necessity of that service being provided. We already talked a little bit about CPT Category 2 codes, where they a lot of times will be bundled and actually are coding or indicating a range of services being provided actually over a period of time, meaning between G code submissions, there sometimes are services that are provided outside of that initial encounter. There's another use for Category CPT codes, which is to report on services specifically for tracking quality or providing incentive reimbursement based on the value of that service provided. And this may define different quality metrics that are components of overall patient care, but don't have, are not a health service in and of themselves as a standalone service. Now, we're moving on, as I already alluded to adding the diagnosis code or the ICD-10 code, which is going to indicate why you did the service you provided. And ICD-10 code set is the current international classification of disease coding manual and code set that we use universally as a healthcare system. And I want to call out that name again. I've already referred to it as the diagnosis coding, but the reality is this is the international classification for disease. This is describing why you performed the service you provided. This is not in and of itself diagnosing. So there are codes that will indicate what the diagnosis is for a patient. These are generally the disease codes, and these are in the first alphanumeric sets of codes from A all the way through just before the finding code, so just before R. And an example here is the E code set, which are the endocrine system codes, and E11 is the type 2 diabetes code. And then there's a point, a decimal point, which then after it, there are going to be quite a few potential combinations of numbers that are going to indicate control, complications, the mechanism of treatment, whether it's the patient is on oral hypoglycemics, they're diet controlled, they're insulin controlled. This is going to give you your final code. And when we are selecting an ICD-10 code, we should be selecting a code to the highest level of specificity possible. So generally, there'll be an alphanumeric character, anywhere from 2 to 3 numerals, a decimal point, and then potentially up to, I believe, 3 numerals after the decimal point. Now, the next line here in the ICD-10 coding manual are the R codes. And these are definitely your friends as a pharmacist. These are finding codes. So these are codes that we can use to define someone presenting for healthcare services when they don't have a defined definition yet. And this is something we'll very commonly see, especially in the retail pharmacy setting. If a patient comes up to ask us and get the pharmacist's initial assessment and triage for a medical condition that has not yet been diagnosed, and we may highly suspect a condition, but without the ability or the authority to diagnose, to bill for that service, we would want to use a code that indicates what the presenting symptoms were. In this case, this patient is here for lower urinary tract symptoms and was asking some questions of their pharmacist. They had a full consultation. In this consultation, let's say we wanted to reimburse for it. The ICD-10 code we would use is R39.9 to indicate that this patient is having lower urinary tract symptoms, probably BPH, but we have not diagnosed that, and we are going to actually refer them to a diagnostician for further workup after having kind of discussed what some of the potential causes could be and the treatment options are. Now, there are a number of other code sets or groupings within ICD-10 that are useful and often used by pharmacists as well. There are complication codes, so the T code set, and this is where you will actually code for a lot of medication-related problems, and there are codes specific for complications of chronic medication treatment or complications of aspirin use or anticoagulant use. We also have external causes of morbidity codes and factors influencing health. External causes of morbidity can include things like accidents, so a patient falling or tripping. This could also be poisonings, so overdose of medications, whether intentional or not. And then factors influencing health, the Z codes, a lot of times will indicate just something along the lines of chronic drug use or polypharmacy, or preventative health. So these are reasons that are not in and of themselves a problem, but it is the reason why a patient would be presenting to a healthcare practitioner for a service, being one that is routine and causes them to come in. So monitoring of a high-risk medication being a perfect example. So now we've gone through where it happened, what we did, and why we did it. The next step is indicating who did it. So this is your credentialing bucket. Now, the first step to identifying yourself as the pharmacist provider, the rendering service provider, you need to establish your NPI, or National Provider Identification Number. And all healthcare providers are required to acquire this identification number through the NPPES system maintained by the government. And when you register, you have to choose a taxonomy to indicate what type of provider you are and what your specialization is within your provider type. And you always have to designate a primary taxonomy, and then you can have multiple taxonomies after that. And we'll kind of go through what some of those look like. But every one of you will have to establish an account and get an NPI, and these are 10 digits long. Depending upon your state, you may have specific guidance from the state, and specifically the state Medicaid agency, how they want you to register as a pharmacist with your NPI. But number one, you as pharmacists are going to register as category 18 providers, and that's a pharmacy service provider. And then you want to select pharmacist. If there is no guidance in your specific state, the recommendation I will provide to you is to register as a pharmacist clinician or clinical pharmacy specialist. You generally want to have this as your primary taxonomy in order to bill for healthcare services. There are ones that are just basic pharmacists that do not include pharmacist clinician. And some of the states that have gone with state provider status have asked their pharmacists to register specifically as a clinician to designate that they will be billing for medical services and not just billing through the pharmacy benefit. The next component after generating an NPI is credentialing. And we talked a little bit about this in the first lecture, but credentialing is overall it's the process of establishing the qualifications of a licensed professional and assessing their both academic background and their training. This is also where licenses and standing with those licenses and other regulatory bodies is assessed. There are 2 to 3 layers to credentialing as a medical professional. The first being personnel credentialing. This is when you're hired with your own organization. They are going to credential you and check to confirm that you have the appropriate qualifications to perform the functions of the position you were offered. The next step generally is state credentialing, and that's with the state Medicaid agency. This does vary to some extent state to state, but if you are going to be billing under state Medicaid, you must, whether it is a managed Medicaid or in Oregon, a CCO Medicaid model, you must have initial state Medicaid credentialing to be able to then credential with the managed Medicaid plans. If we were federal providers as well, there would be a separate step in parallel where it would be federal credentialing, and that would be submission of application to work within the Medicare program. And then the final step is insurance credentialing. So that's with the actual payer themselves. So that's your managed Medicaid plans. That is your commercial insurance plans. And if we're talking the federal route, that would be managed Medicare plans. Now, each company is going to set their own criteria to verify that the provider has the credentials or the education, the training, and experience that they want. A great example is here in Oregon, we have a number of different plans that credential pharmacists, and one of the plans in particular requires that pharmacists to bill under the medical benefit have either a completion of an accredited residency or they are board certified. Now, not every one of the payers requires this, but that's the most stringent credentialing criteria that we have in our network of payers at the moment. So that's what we've had to set organizationally as our standard for what we request from our clinical pharmacists that we're recruiting and onboarding. Because if they do not have that and I can't credential them with that payer, I can't get reimbursed for their services. So it's actually the payers and their credentialing standards that dictate what the professional standard becomes for expectations on training. Now, there are some states that have credentialing and they do not require that. And there are some states where to even be able to bill for service, to have privileges within the state, to be permitted to function as a pharmacist clinician, the state themselves, their board of pharmacy, have required residency training or board certification.
And I'd like to add a little bit to that too. When we talk about credentialing at Care Oregon, the importance of having the right taxonomy is brought up quite frequently. In our state, we cannot reimburse a provider unless they've been credentialed with state Medicaid, and we can't even reimburse a pharmacist unless they've updated their taxonomy and NPI appropriately with the National Plan and Provider Enumeration System. So having that pharmacist clinician or clinical pharmacy specialist on there is incredibly important and often overlooked by a lot of our colleagues in the pharmacy world. And we verify every pharmacist that we credential here. We don't have strict standards like the ones that Zach was talking about, but plans do have the ability to do that in some states. That's not always the requirement though.
Yeah, absolutely. And if we look at physicians just as another allied health professional who goes through a very similar process, it is stated and expected that all physicians will go through, once they get their medical doctorate and they are licensed in a state, they will go through a residency training, possibly fellowship, and get board certification before they can independently practice. And that's not because the scope of practice in the states limits them. That is simply because that is the expectation by the payers. A medical doctor can come out of medical school and has privileges granted by the state that they're practicing in. They just can't get reimbursed based on credentialing standards. I think the one other component to call out is, as we talked about, primarily focusing on education and training, there is this standing that we mentioned, and that's standing with the board of pharmacy or whatever your professional board is. So if there is action on your license that can limit your credentialing, you may be excluded from participation in a particular plan. But when we talk about standing, very much in particular, we're talking about whether or not you've had federal action taken and have been put on a federal exclusion list from being reimbursed with federal healthcare dollars. And what would cause that would be felonies under the Controlled Substance Act or felonies related to healthcare fraud and abuse. So if you have been found guilty of a controlled substance related crime or healthcare fraud, you for a period of time or potentially permanently are put on an exclusion list from being credentialed. Here, we map this out visually so you can see the process. Both, we want to start on the facility side. So once a facility hires a pharmacist, we're going to move on to that personnel credentialing. So this is where we're looking at that initial credentialing and then the concurrent process of privileging that occurs, where once the facility has granted credentials, approved credentials, they then grant privileges saying, yes, you have the education and training to be a clinical pharmacist with us. This is your scope of practice within our site, and you may provide services X, Y, and Z. Then the next step is to move on to state credentialing. So you submit an application for credentialing to the state and obtain a state Medicaid provider ID. And then you move on to insurance credentialing. Once that ID is obtained, you then generally apply. It sometimes is the same application. Depending upon your location, it may be a completely different form. And this is why we have whole departments dedicated to credentialing who deal with navigating the books we have to submit. but you would submit a credentialing application to each payer in your network, and then we move on to contracting. Generally, contracting itself happens before credentialing, but if you're providing services, perhaps clinical pharmacy services that are new and weren't included in the contract, you have to go back to the process of contracting with those insurance plans to add a fee schedule for pharmacy services. Now, the contracting process is on the other side here, and with the contracting process, really you want to start with privileging. What are the services you want to be providing within your service site? You identify what those services are, and then you work with the plan, the payers, to establish a contract that has a fee schedule for the services you want to provide, and those services are going to be defined by the CPT codes that code for what we've done. The next step is identifying how you're going to submit those claims. Is the plan going to let you be both a billing and rendering provider? So are they going to fully credential you, which means you will be submitting a claim under your own individual NPI? Or is it going to be billed by the facility, the pharmacy, or potentially another provider? And then the pharmacist would be the rendering provider, where your NPI would be submitted on a separate line on the claims form that says, I performed this service, but I'm not billing for it. And then there's this process that's always ongoing of recontracting and recredentialing, where you have to generally it's a 1 to 2 year process. I think most sites try to do, well, that varies by site. We specifically try to keep our contracts on a 2-year cycle, so they're getting reviewed on a routine basis to make sure the fee schedule we're getting reimbursed is keeping up with inflation and the cost of care delivery, and that we are keeping up to date with our providers.
Yeah, and another point there about the statewide credentialing, which goes along with this, is all states have to submit to CMS a common credentialing application form that creates a baseline minimum of required credentialing for all provider types, regardless of the health plan. And one of the things that health plans have to do is follow that. They can be more stringent, but they can't be overtly stringent unless they can prove network adequacy. So if we are limiting providers' access into a network based on credentialing, and a grievance claim is reported to the state, we have to prove to them that the reason why we have tighter credentialing is because we have an abundance of providers within our network to satisfy our commitment to the state and to CMS in regards to providing care for our membership. And one of the biggest barriers in Oregon, I think, is getting that out, that pharmacists are expected and in fact required to be credentialed to the Oregon Health Authority, even if you're prescribing immunizations, ordering labs, or working under a collaborative practice agreement. It's the expectation that the state that you submit your credentialing application with the state. Otherwise, you'll get rejected claims for administering an immunization shot, like at a Rite Aid. And we have a lot of pharmacists not doing that. A lot of organizations refusing to do that, and it's leading to a lot of lack of reimbursement for services that are just being provided for free, just because the credentialing process is time and operations, and it hasn't been really an expectation for pharmacists at all. And that's certainly not in Oregon since 2015.
So this here from the Oregon Health Authority is an example from our state. Once you have your NPI and you're licensed in the state, this is the actual portal on the Medicaid website where you can download the required forms to register as a pharmacy services provider as a pharmacist. And pharmacist provider type under the Oregon Health Authority's credentialing is provider type 50, but there are subspecialties within that. In this case, you can register as a pharmacist who will have services billed by the pharmacy. So this is your dispensing pharmacist who may be doing medication therapy management services, but is not billing independently. That bill is being submitted under the pharmacy's NPI and being reimbursed with the pharmacist as the rendering provider. And then we have pharmacist registration as a medication therapy management service provider, where they're billing directly and the reimbursement is going directly to the pharmacist. And then we also have pharmacist as a prescriber of hormonal birth control. And the state has not kept up with changing their forms as pharmacist scope of services and scope of practices has been increased by the Board of Pharmacy in the state. But either the Specialty 106 or Specialty 109 are generally used at this point for pharmacists who are billing for clinical services outside of traditional medication therapy management or just contraceptive prescribing. And yes, so in 2015, we did have an update to the scope of practice. Medicaid has been lagging behind in updating our registrations. And I've had some communication with them. I know Andy has as well. It's something they're aware of, but it's a very slow process.
It's surprisingly expensive to fix.
Yes. So now we're on to our last bucket. We have all of the pieces we need to put together a bill for services. We know where this service happened. We know what we did. We know why we did it. We know who we are and can say who we are. And now we're going to code it. Now, there's two different types of billing forms, and we're not showing them to you here. I do recommend you go look them up and just see what the format is so you can see the content of what's on them. But the CMS 1500 form is what we would use for non-hospital outpatient visits and procedures. So that's an office visit for evaluation and management services, or MTM. That's immunizations, lab tests, and so forth. And then there's the UB92, also known as the CMS 1450 form, which is used for hospital outpatient visits and billing facility fees. And you'd likely see this more with a Coumadin clinic or hospital-based practice that's performed in the outpatient clinics around or operated by the hospital. But the reality is these claims are submitted electronically in almost all settings. There may be a few small independent practices who are submitting paper claims, but these are populated by either your dispensing software or by your EMR.
And it's also point out that health plans also have to have a provider portal to submit paper-based claims if their EHR isn't capable of submitting them electronically. So health plans have to accept paper-based claims still to this day. We don't like to, but we do. And I also want to point out with the UB92 claims form, that doesn't imply that the provider isn't able to bill outpatient covered services under the CMS 1500 form. That form is just specifically used for the facility fees and what's included as part of that facility fee.
So now we're going to move into what the actual CPT codes you'd be selecting for various services are. Now that we've looked at the process of becoming an in-network provider and getting a provider ID and being able to document and code for services, let's look at how we actually code that. And we're going to start with the medication therapy management service codes. So medication therapy management service codes, when we talk about them, are going to cause a lot of confusion, and it's not going to get better. And that's because there's a ton of definitions for them. And there is the American Medical Association, the AMA definition of medication therapy management, which is specifically what I'm talking about when we talk about billing the medical benefit. And this is the CPT codes 99605, 99606, and 99607, which are defined and maintained by AMA in the CPT coding manual. And these are distinctly different from MTM. When we talk about it to other pharmacists and our pharmacy partners, we're generally thinking Part D MTM. And these codes did come out of the work done to create the Medicare Part D MTM definition, but Medicare Part D MTM is limited to specific conditions where there are a certain number of pre-specified disease states and medication burden, and is billed to the pharmacy benefit for recipients with Medicare Part D, whereas the AMA MTM codes are used for really any type of situation where you need to be assessing and managing specifically a patient's use of medications. And then there's this whole other level of confusion where the states themselves may have definitions for medication therapy management, or MTM. And using Oregon, our state, as an example, Oregon's Board of Pharmacy definition of MTM, which is one of our scope of practice definitions, is different from both of these other definitions. So to really sum that up, we want to be looking at the AMA CPT definition for this. Now, Medicare Part D MTM, it is important to know what this is. And Andy, I might actually ask you to chime in on this because you do work with a plan that has a Medicare Part D program dealing with MTM. So do you want to talk a little bit about this?
Absolutely, Zach. So Medicare Part D MTM and the true definition of MTM defined by the AMA are really two separate and distinct services altogether in all actuality. When we're talking Medicare Part D MTM programs, that's for targeted beneficiaries and used to improve medication use, reduce risk of adverse events. And these are developed in cooperation with the health plan's P&T through practicing pharmacists and physicians. And they can be furnished by pharmacists or other qualified healthcare providers under the Part D benefit or pharmacy benefit. And they're limited to target populations, as Zach was saying. So we're talking common disease states like diabetes. There's actually about 12 of them, core ones that we can choose from, and several mandatory disease states that we have to include in our Part D submission to CMS for approval. These codes, Part D MTM doesn't specifically use a CPT code. The services can occur face-to-face or telephonic. And payment comes out of the health plan's pharmacy department's administrative budget costs. So what does that mean? That means the pot of money that we use to pay our employees, we have to ask for an account for that when we reimburse Part D MTM. It's not a dedicated fund like a medical benefit would be for CPT coding costs, which are built into the claim and built into our submission. Now, the core services of Part D MTM differ widely in terms of the true definition of MTM described by AMA. They involve a comprehensive medication review, or TIPS, or targeted medication reviews, where you're identifying certain drug therapy problems like just adherence, or is this patient not on a statin, or doing the full gamut in a comprehensive medication review. Those terms don't exist in the medical definition of MTM. The documentation includes 3 components, which includes a progress note, which doesn't really have a defined algorithm. So often those are a SOAP or a SOAR-based notes, and a medication action plan and a personal medication record or PMR. These components are required components for a CMR to be part of, but those are absent when we're considering AMA. And the eligible providers for comprehensive medication reviews include pharmacists, physicians, nurse practitioners, physicians assistants, registered nurses, and eligible MTM providers able to provide targeted services include pharmacy technicians, caseworkers, pharmacy interns, and a very loose and gray term as other. So when we talk about medication therapy management under the Part D benefit, it's not specific to pharmacists. It's not something that only pharmacists can provide. A wide variety of providers can provide it. And the services are clearly defined on what constitutes a CMR versus a target medication review or TIP. Now, for me, that's pretty damaging because it allows health plans to not use nurses even to provide a service that pharmacists are very more well equipped to handle. And certainly, we wouldn't want caseworkers or definition of other, which still remains gray, to be doing anything that has to do with medication targeted reviews, but that is allowed to a health plan and can be approved by CMS. And we're not billing the Part D MTM, like I said, under the medical benefit. We're not using a CMS 1500 form. We're not submitting these through an electronic health record. There's what's called overlay software systems or third-party software systems that are used, like Outcomes MTM or Rexa or CSS Health or Synopia, where we load patients who are part of this medication therapy management pool into that system and identify them by the services that they qualify for based on an algorithm that we've been approved by CMS for pharmacies and other providers to work on. So it's very, very different than when we talk about medication therapy management billed under the medical benefit by a pharmacist clinician.
Now, MTM services billing under the medical benefit is much different, and you'll see here, it is defined as being face-to-face patient assessment and intervention. It is provided by a pharmacist only, and upon request or referral or pharmacist discretion. So what this here tells us, being different from Part D, is that, one, site matters in this case. So to meet the definition of this CPT code, it has to be provided face-to-face, and it must be a pharmacist. So there must be a pharmacist NPI attached to a claim with the CPT code. And the overall intent is to optimize response to medications, or manage treatment-related interactions or complications. Now, the documented elements that have to be in the documentation or note for this encounter are really three components. It's a review of pertinent patient history, and when they say patient history, it's not defined. It has to be a review of the medication profile, and then recommendations for improving health outcomes and treatment compliance. That is going to give you some scope for what this is and can be, and there's no definition here that this is only for targeted individuals who have 3 or 4 chronic disease states. These patients don't have to be on 12 medications. They could be on one single medication and have poor adherence, and we want to have a pharmacist intervene with them to look at what the barriers to adherence to that medication are and make some recommendations for how that patient can change their use to improve outcomes. There's no notation or requirement for there being any type of physical examination or laboratory examination. We are simply looking at how a patient is using medications, how they report they're using them and what they're for, and then there are recommendations by the pharmacist.
So one way to think about that is when we're talking about medication therapy management is it's recommendation-based care. You're recommending someone else to do something to improve the outcomes for this patient. You are not doing it as the pharmacist per se.
There are 3 codes for medication therapy management, and they are time-based codes. The time-based codes are the 99605 and 99606 for the initial 15 minutes. So there's 2 initial 15-minute codes. And the 605 is indicating that this is a patient who the pharmacist has never seen before. And the 606 is indicating a patient that the pharmacist has seen before. So once you've hit that 15-minute threshold, you can drop the initial claim. That's either a 5 or a 6. It's one or the other. If that encounter, that visit with the patient goes on for 30 minutes, 45 minutes, 60 minutes, you can add on units of 99607 for each additional 15 minutes beyond the initial code. These codes should not be rounded. So unfortunately, if you did 25 minutes of counseling and intervention with the patient face-to-face, you should just bill your 605 or 6. But if you did 30 minutes, 31 minutes, you could do a 99605 if they're a new patient and a 99607. Both of those codes would go on to the same claim and you would get reimbursed for that. Now, Oregon Medicaid has an established fee schedule for these services. These fees, I do feel, are not representative of the work being done and need to be increased, and they haven't been increased in some period of time, so there's going to be some work done there. But this is to give you an example of what, just for medication therapy management services, a pharmacist could be reimbursed. For example, if you scheduled 4 15-minute visits in 1 hour, you could be receiving about $120 in reimbursement, maybe a little bit more if they were all new patients.
Another thing, I just want to interject a little bit here. Zach's absolutely right. The reimbursement rates that the Department of Medicaid and the Oregon Health Authority, when pharmacists got provider status for MTM, that happened actually in 2009. So when we talk about provider status for pharmacists, we are not talking just MTM. That should not be your focus. In Oregon, we've had provider status and the medical benefit for MTM for well longer than we had for the passage of House Bill 2028 in 2015. These are just specific services, specialty services is how they're categorized, that a pharmacist provides.
Now, this is just a summary for you for differentiating medical MTM. So CPT codes 99605 through 7 in Part D MTM. And just one caveat here, some Part D plans may ask you to submit a 99605 through 7 code, and that's not inherently wrong, but when we are talking about it, or if you get an exam question on this, we are talking about billing the medical benefit. But for Part D MTM, this can be billed by really almost any healthcare licensed professional, potentially some non-licensed individuals, depending upon the plan. Medical MTM can only be billed by a pharmacist. The service for medical MTM place of service must be face-to-face. This is a higher level of autonomy in that this is a service the pharmacist can provide and can self-identify that a patient may need this service. And when this is a covered benefit under a health plan, there's really high access to this because this can be rendered, it doesn't state specifically that it can only be done in a certain location. It says it can be face-to-face. That could be in a pharmacy, that could be in a clinic, that could be in a hospital, depending upon the patient's individual benefits. So there's high access to this. And you don't need a collaborative practice protocol for this or prescriptive authority delegated under your board of pharmacy. This can be something that you can do even without prescriptive authority or a collaborative protocol. We want to go through an example MTM case here. So we have a patient, Mrs. S, who's being seen again. This is going to be a follow-up medication therapy management service, and she is a patient with type 2 diabetes. We spent 45 minutes preparing for the visit and 15 minutes documenting this encounter, and she has uncontrolled diabetes. She was educated, and she does have uncontrolled diabetes due to some variability in her regimen. She's getting both hypo and hyperglycemic numbers on self-testing and having symptoms of both. So we spent a lot of time educating her on the signs and symptoms of hypo and hyperglycemia. We discussed proper insulin use with the patient, asked her to show us how she's drawing out insulin into her syringes and injecting it. And we provided some recommendations back to her provider to make some changes to her insulin. We did request a referral for clinical pharmacy services to follow her, and we're going to follow up in 2 weeks to again discuss diet and exercise and other risk factor reduction to help her control her diabetes. And in our documentation, we briefly documented what we spoke with the patient about, the history we took, and we documented that we spent 30 minutes face-to-face with her discussing medication regimen, both her prescriptions. We looked at her herbal supplements to see if any of them may be impacting her overall care, and we looked at her over-the-counter medications. Now for this, because it was 30 minutes spent face-to-face, we can drop one code of 99606, and we chose 6 because she was established with us. We knew her already and had seen her previously for medication therapy management. And it was 30 minutes, and that code counts for just 15 minutes. So we're going to add a second code for 99607, indicating the additional 15 minutes. And in this case, both of these are linked to the diagnosis of diabetes mellitus type 2, which is E11, and the 0.9 is indicating that she is insulin controlled, or rather on insulin for diabetes control. And in this case, we are managing specifically her complications of medication treatment, namely the hyper and hypoglycemia that she's experiencing from the way she is using her insulin. And we're trying to make a recommendation for the provider to switch her to a long-acting insulin that has lower risk of hypoglycemia. And because we were not directly managing this under a collaborative protocol, and we're focusing on her use of medications rather than the overall disease itself, this is why we're billing a medication therapy management code. Now, I really hope we did have in the example, for the purposes of calling out, there were 45 minutes spent getting ready for that visit. We cannot code for the non-face-to-face time. Andy, and for those of you who don't know, Andy was my resident as well. If you spend 45 minutes getting ready for a diabetes visit, you're going to come back to residency and start over. But just for the just for the purpose of an example here, face-to-face time with the patient is the only amount that can be coded. You cannot use documentation time, and you cannot use preparation time.
That's right. All right, now we're going to switch gears a little bit and focus on E&M coding and billing, which is very different than what you would think, what we just went over, which is medication therapy management or recommendation-based care. E&M codes are used for the general provision of healthcare services, and there's a variety of E&M codes out there. In fact, there's E&M codes for nearly every site of care, including critical care services, inpatient services, skilled nursing skilled services, telephonic evaluation and management codes. They really across the breadth of healthcare, and that's why they're considered the general provision of healthcare services and how we use these. The general definition of E&M is similar with respect to MTM in the fact that it has to be face-to-face professional service. The code that you use will imply that this was a face-to-face service, or you would use an E&M code for a telephone-based encounter, which has a different coding set. They have to be provided by a physician or other qualified healthcare professional. It follows the EMA CPT coding manual and the 1997 and 95 E&M documentation guidelines that are produced by CMS, which they describe the type of patient you're seeing, whether it's a diabetes patient with hypoglycemia or with complications, or a hypertensive patient, and that's why we use the ICD-10 codes when we build these services to identify that. It also describes the setting, the place of service, where this service took place. And the E&M code itself, the CPT code, is used to describe the level or complexity of the patient that you're seeing, the amount of work, the amount of medical decision-making or time that was spent with the patient in counseling or coordinating care or educating them on their disease state. They're used for the documentation and payment and provision of general healthcare services, and we have codes just like MTM for new and established patients. And the codes that we use have a built-in standard weighting system, which describes the extent of delivering that healthcare services from the work that was done by the provider to the lights on, doors open, and practice expenses and clinical staff of the provider that they're utilizing, such as an MA or a nurse, and also describes the malpractice and liability insurance that a provider takes on when they're owning care. And this is when we're talking about owning care, or when someone's asking, what's your intervention? You should be asking them, are you talking about MTM? Or what's your plan of care, which is more associated with evaluation and management? You are the provider that is planning and owning the care for this particular patient for this disease state. And we use these for the purpose of reimbursement. Now, there's 4 steps that I want you guys to focus on when you're using to identify the type of code you need to use and the documentation components that are required for those codes. The first thing I want you to do is identify if this is a new or an established patient visit. The second thing is I want you to identify the initial level of billing based on the amount of face-to-face time that was spent with the patient for medical decision-making. So that will be always clearly, we will always put that on your case, how much face-to-face time we spent with the patient, and that will be included on any test question. So pay attention to time. Step 3, I want you to determine if the documentation supports the level of billing, higher or lower, based on the history that was documented and the exam performed by the provider within the note, and the level of complexity or medical decision-making that was done by the provider when assessing, evaluating, and managing that patient. And then I want you to identify the final code based off of the documentation and the time, and choose the correct code that's appropriate for the service that was rendered. So when we talk about a new patient, what does that mean? Well, a new patient is clearly defined by the AMA as a patient who has received any professional service from a physician or other qualified healthcare provider in the group of the same specialty within the last 3 years. Now, if you're a pharmacist working in primary care, your specialty is primary care. If you're working in behavioral health or mental health institute, then your specialty would be in behavioral health or mental health provider. So the providers that you're working around you are of the same specialty as you. So just because you're a pharmacist doesn't mean you're a specialty that's different than the nurse practitioner or physician that you're working alongside. If it's the exact same specialty, you would be, then it would follow that 3-year rule and be a new patient if they haven't been there. But if they have been seen in the first 3 years, then they're considered established. So it's pretty easy when you think about it. They're either of your practice or not of your practice, and they haven't been seen in 3 years, then they're new, or they have been seen by the practice, by you or another provider, and they're not, and then they're established. Now, when we talk about the level of evaluation management, the level of service, that encompasses about 7 areas which define the level of an E&M service. History, examination, and medical decision-making are the key components. They are the core components of any evaluation and management encounter and how you document them. But there's also counseling, coordination of care, nature of presenting problem, and time, which are also contributory factors that can be used sometimes to substitute for a core factor or add on or augment the case to justify the code that you're using. And time can be used as a proxy for the work done before, during, and after the visit for an E&M encounter. So it could be some of the prep work or some of the time that was spent reviewing old records or obtaining old records from the patient's previous provider. So time can always be used as a proxy. Now, this is AMA's cheat sheet guide that I've always had taped to my computer when I was practicing as a resident with Zach Roscoe. And I encourage everyone to get familiar with it and use it. A new patient uses the codes 99201 through 99205. The 0 designates that is a new patient to the provider. 99211 and 99215 is an established patient. And because most pharmacists are working on collaborative practice agreements, most of the time in Oregon, pharmacists are billing established E&M codes. And the required components for new versus established are different. There are more components required for a new patient to the practice, because it would require a lot more in-depth evaluation and examination by you as a provider. So 3 out of the 3 of the core components must be present in order for you to bill that service. Whereas an established patient, only 2 out of the 3 required components are required. Now, history and exam are required components 1 and 2. They can be problem-focused, expanded problem-focused, detailed, or comprehensive. And the degree and level of detail and comprehensiveness goes up with the code. Medical decision-making or complexity, how complex the provider's assessment was in choosing a treatment or examination or procedure option, is the core component number 3, and is by far one of the most important components by far when you're deciding to choose what level of service that you're going to use for that visit. Now, presenting problem severity can substitute for history, counseling can substitute for exam, and coordination of care can substitute for medical decision-making. And time, which is the average time that is typically spent providing care for these types of patients, for the complexity of these patients, has been well defined by AMA over the last 70 years, actually. And the typical time is what a typical average provider would spend assessing or managing a patient would be associated with this code. There are 10, 20, 30, 40, and 60-minute time frames, and these are ranges of times. That's another thing to point out. You have to be within the range of this time to use it. So if you spent 55 minutes with a patient, you wouldn't round up to a 60-minute visit. You would round down to a 45. These are round down codes, similar to MTM in a way. And for an established patients, the times are much less because we're not doing as much initial evaluation in terms of our documentation. So 5, 10, 15, 25, and 40-minute visits would be the range that we would use for these CPT codes. When we talk about history has 4 components and 4 categories that you need to focus on. A chief complaint, or CC, is required for all evaluation and management visits because they are problem-based visits. Problem-based visits always have a chief complaint. If there is no chief complaint, then it is assumed that this is a preventative medicine visit. History and present illness can be problem-focused, expanded problem-focused, detailed or comprehensive. Review of systems follows the same type of logic. And the degree of review of systems and history that you document can determine how detailed or comprehensive your history was. And that's used to codify and assess whether or not you're choosing the right code or not. Past family and social history, otherwise known as FISH from this point forward, is also used. So if you're taking a history of the patient's family history or what their social history, or whether they're smoking or how much or how often do they have an alcoholic beverage or their sexual practices, all of that is included when you're assessing the degree and intensity of the documentation for history that you did. So when we codify history, we assess each area individually. So when we're assessing whether or not we had a problem-focused visit or a brief visit based on a history of present illness, we can have brief or problem pertinent, but review of system, if we have a more extended review of system or a very complete or comprehensive history, you always want to backfill that to the lowest degree in which the history documentation category fell in. So you can have a complete history, but only a brief HPI, but you would not say, okay, we don't split the difference and call it a detailed. We would call that a problem-focused visit because your history of present illness was only brief. So you always default to the lowest setting. Now, this is a diagram that kind of wraps everything together, so let's walk through it. When I talk about history and present illness, we're talking about 8 categories. Location of the problem. Where is the symptom located? Is that in the foot? Are they feeling pain in their knee, etc.? The quality of the problem is whether it's dull, radiant pain or shooting pain. The severity of the problem is how severe it is, and that's usually done on some type of standardized pain scale or other assessment. Timing is when does it occur? When is it most frequent? Context is when is it happening, or what makes it better. And modifying factors can also tell you like what they've tried in the past that have helped alleviate that pain, like medications that they've taken over the counter for a headache. How long the pain lasts is duration. Does it last 2 to 3 days, 4 to 5 minutes? Pain's a really good example to walk through these. This is why I'm doing it. But this applies to all situations when you're assessing a patient. And associated signs and symptoms are other additional signs and symptoms that may be related to the current problem, or as a result of, or contributing to the current problem that the patient is experiencing. Now, these can be brief. If you document 1 to 3, it's considered a brief history, HPI. It can be extended, which is 4 or more of those of the domains documented, or the status of 3 chronic conditions. So oftentimes, pharmacists are managing several disease states under collaborative practice agreement, and they may be reporting on diabetes, blood pressure, cholesterol. Already, if you're reporting on the status of those diseases, whether they're controlled, uncontrolled, what their current treatment regimen is, how adherent they are to their current treatment regimen, you're already going to be in an extended history of present illness category. Now, review of systems is a questionnaire, a standardized questionnaire that's based off of 14 body systems, where a patient is asked a series of questions. This can be done by you, the clinician. It can be done by clinical staff. It can be filled out by a form prior to the office visit by the patient even, and then reviewed by you, the provider, during the visit and extrapolate into the chart note. And it's just seeking to describe other associated signs and symptoms. So associated signs and symptoms, a component of HPMI, and review of systems are very similar to each other. Now, you can't, once you've documented over 4 review of systems within your chart note, I'm sorry, I'm going to back that up there. Once you've documented 4 associated signs of symptoms within your HPI, you then start counting your other associated signs and symptoms to your review of systems. Now, review of systems can either be not there, problem pertinent, having 1 bullet, extended, which is between 2 and 9 bulleted, or complete, which is greater than 10. Now, this is often described as not symptom not present or denied or negative. These are your problem pertinent or negatively pertinent associated signs and symptoms associated with the condition that you're describing. Now, past family and social history help dictate, so let's back up again. Review of system also can help inform you the degree of physical exam that you are going to be providing to the patient today. So if a patient is experiencing other associated signs and symptoms in a bodily area, it would be pertinent for you as a provider to perform a physical exam or recommend or get assistance from another provider to review that, to examine the patient to ensure that these associated signs and symptoms aren't something altogether more drastic for the patient, or is it a new problem altogether that you're experiencing? Now, the FISH, or past family and social history, is really pretty straightforward. It's not required for 99201 through 99202 or 99212 through 99213, but they are required once you go going into the more moderate levels of services, your 3s and 4s and 5s. And they can be either detailed, which is reporting on 1 component of past family or social history, or it can be complete, which is reporting on all 3 or at least 2 for an established patient. And if you're billing a 5 for an established visit, you would at least have to report 2 of those within your chart note. So when you're assessing and codifying whether or not your history is extended or brief or problem focused or detailed or comprehensive, you are always going to backfill this. So if you did an extended history of present illness, but in a complete history, but only had a detailed review of systems, you would choose the detailed level of service for your history. And that would either be a 3 for a new patient or a 4 for an established.
So jumping into physical exam, and we're just going to give you the caveat here. We're going to use the 97 evaluation and management guidelines for physical exam. It's a lot more straightforward. So, and you are permitted to pick and choose from 97 and the 95 guidelines when doing the documentation, specifically with the physical exam as well. So for physical exam, there are 4 levels of exam that mirror our levels of history. There's a problem-focused examination, there's an expanded problem focus, a detailed, and a comprehensive. And a problem-focused examination is going to have 1 to 5 elements of the physical exam identified by a bullet, and we're going to go through what those bullets are. An expanded problem-focused exam has at least 6 elements identified by a bullet, but less than 12. A detailed exam has at least 2 elements identified by a bullet from each of 6 different body areas or systems, or at least 12 elements identified by a bullet in 2 or more areas or systems. And comprehensive is going to have all elements identified by a bullet in at least 9 systems. The comprehensive exams are, quite frankly, it may be your true physical exam, but that's more likely a detailed exam. Comprehensive exams are generally performed by specialists in a specific subspecialty, looking at very detailed examinations of a number of associated systems. Now, the first system on here, and really, if you're providing evaluation and management services, so problem-based encounters, you should be documenting constitutional on every one of your patients. In constitutional, there is a maximum of 2 different bullets in here. The first bullet being the measurement of 3 of 7 vital signs, and that's standing or supine blood pressure can each be a bullet, pulse rate and regularity, respiration, temperature, height, and weight. So generally you are going to have 5 or more of those vital signs documented for your encounters, but a minimum of 3 is required to get 1 bullet. And then you get another bullet for documenting the general appearance of the patient. So this is a well-appearing adult male or female in no apparent distress. Those are 2 bullets for physical exam, and guess what? You as a pharmacist have just performed a physical exam, and you could get 1 bullet without even touching them. And that would quantify a problem-focused physical exam. Now, the bullets then get a little bit more convoluted as you move on to the different organ systems, and understanding what's going to qualify as a bullet does go back to understanding the process of physical examination, which is broken down into 4 different components for each system. Physical examination is starting with inspection, moves on to palpation, percussion, and auscultation for all organ systems other than abdominal. Now, generally, you'll get a point for inspection, you'll get a bullet for palpation, you'll get a bullet for percussion, and you'll get a bullet for auscultation in each different organ system. There may be separate bullet points if you are performing that component on different structures within that organ system. So a good example would be the cardiovascular system. So we have palpation of the heart. So this is a process by which you're feeling for the size of the heart. When we're talking about palpation, we're looking for palpation of the PMI, the point of maximal impact, which is where the apex of the heart is hitting the chest wall. And that gives the clinician an indication to whether or not the heart is enlarged and there may be cardiomegaly present. But you can also get a bullet for another palpation, for palpating the carotid arteries or any of the other pertinent arteries in the cardiovascular system, for pulse, for the amplitude of that pulse as well. So there are generally a minimum of 4 bullets in each of the other examination systems. Now, we're not going to expect you in the scope of this lecture or this class to memorize all of the possible bullets from the organ systems. I think it would help to just get a general idea of how the systems are broken out in the 97 guidelines, but really the emphasis here is at a minimum knowing what your constitutional exam bullets are. And I think another area where pharmacists should be making a comment, especially in the scope of disease state management work, is the psychiatric examination. Really, and this is what we train our pharmacists to, at a minimum, we are getting vitals, general appearance, and mental status, and mainly a comment on mood, affect, and if it's appropriate. So is the patient aware of their surroundings and engaging in conversation, and do they appear as if they're able to care for themselves and carry out a care plan if delivered to them, or are there concerns of their mental state where we may need someone else to actually implement this care or be involved in the care? But a couple of components here. This is, again, limited by your state scope of practice, which is defined by your board of pharmacy, and it is also defined on your personal and professional competence. So not every pharmacy school teaches in-depth physical examination. It's becoming a little bit more commonplace, and if I had my say, it should be incorporated in all pharmacy school curricula that we are able and competent to perform comprehensive physical examinations. But there are certain training programs available for pharmacists. There are at least 3 in the United States at this point where you, whether you're a student or you're a practicing pharmacist, can get full training in the whole process of physical examination, but you need to know your boundaries. It takes hundreds and thousands of examinations of a specific system to be completely competent in both identifying normal and abnormal. So only document and bill for and perform what you are competent in, and you can perform in the scope of learning, but if you're going to act on any of your findings, in that case, you would want them supervised or confirmed by someone who is competent in that procedure.
And, Zach brings up a good point there. There's also a lot of visual inspection that we do as pharmacists that could qualify for additional points. And some of the other easy ones that we see is the musculoskeletal gait, how the patient is walking when you're taking them from the waiting room into the patient room. You can assess that on your way into the office, and that can be documented as a point too, whether they're shuffling, whether they're moving, whether their head's down, is it a normal gait? There's a lot of basic visual inspections, but as Zach said, this is something that you can't master in the course of a training, and probably not even in the course of a pharmacy school. It takes thousands of lungs to get comfortable figuring out what being competent in assessing the lung function. And so this is something you will gain as you become more competent as a provider and as you grow as a professional.
I was going to say, that's really what your IPPs start to get you introduced to, but this is more your APPs and your residency training that is going to really build this competence.
And it's also pointed out that this may be an area of deficiency in the curriculum for pharmacists, but it's also, when we're talking about an established evaluation and management, that only 2 out of the 3 components are required. So history and medical decision-making or time can be used. Physical exam is not necessarily needed or qualified during that established patient encounter. So a detailed physical exam isn't required necessarily. I mean, always take your constitutionals, because it's an expectation of healthcare to take blood pressure and basic general appearance of the patient in every visit, as Zach said. But it's not used to codify or determine the level of service for established patients. Now, when we talk about the complexity of medical decision-making, this is really the meat and potatoes of E&M, where it scares a lot of pharmacists, and it's always confusing to me and Zach on why, because when you break down the components of medical decision-making, it's really not that difficult. There's 3 categories when determining medical decision-making: the number of diagnosis or treatment options. And I'll highlight treatment options because that's an area where pharmacists are experts in, right? We are the therapeutic experts. So it's not about diagnosing. It's also about determining what treatment options are appropriate for the patient, given other factors or their current medication regimen. That also goes into your medical decision-making as your component 1. That can be minimal, limited, multiple, or extensive. So you could be accessing a number of different diagnoses. The amount of complexity of data reviewed is the second component, which can be minimal or none, limited, moderate, or extensive. Risk of complications of morbidity and mortality. So whether or not this patient is going to have severe complications if something's not done today. So a high risk patient would be someone who you're really worried about the next couple of days of going into the hospital or ER visit if you don't do something right now to alter their plan of care. Or it could be a medication that requires very close therapeutic monitoring, like clozapine, for example. The type of decision-making you choose is either straightforward, low complexity, moderate complexity, or high complexity. And you must meet or exceed 2 out of 3 of these elements to qualify. It's appropriate to use time as a predictor of complexity. If 50% of the time that was spent with the patient was counseling or coordinating care, so referring care to the provider or setting up adherence filling with a pharmacy, those things need to be clearly documented in your plan when you're seeing the patient. And that can be used to justify, and that's what we call time-based billing. So a low complexity example patient would be your typical controlled hypertensive patients, or anti-coag, for instance, is usually considered a very low complexity visit. Contraception. These are straightforward medical decisions for the most part. So medical decision making also focuses on the nature of the presenting problem. Whether this problem is controlled versus uncontrolled. Is this a new problem to the provider, or is it a problem that you're following up on? All can give you a higher level of medical decision making based on the circumstances. The number of diagnosis or treatment options is always very important. If you're assessing 3 different diagnoses that 2 of them are controlled, one uncontrolled, that is also considered, and there's points assigned to those when determining your medical decision making. Summarizing previous chart notes, but that has to be summarized within your documentation in order for it to qualify, is also used. So this is a lot of your assessment and plan portion of your chart note, whereas the history and exam would be your S and your O. And we already went through the 50% of the encounter for time has to be spent counseling and coordinating care, but it has to be, the time that you spent has to be medically necessary. You don't want to be counting time or side conversations where you're talking about the patient's talking about their dog or what their daughters are doing. Those don't go into that determination of face-to-face time. It is the time that is spent, the medically necessary time, educating that patient and counseling them on how to improve their treatment or healthcare status. Now, when we're codifying complexity based on the diagnosis or number of treatment options, we can have self-limited or minor, stable or which can be a minor or self-limiting condition is like a mosquito bite or a basic rash. These things usually are self-resolving. They don't require a medication to be treated, or an over-the-counter medication may be appropriate in those types of situations. You get a max of 2 of those for the number of diagnoses. So in the numbering, if we had to, we would multiply that out by the points associated with them, and that would give us our result. For an established problem to the examiner, it can be stable or improved, and those also get 1 point. And you can have multiple of those if you're assessing many different stable and controlled conditions or improving conditions. Or an established problem that is worsening, that will give you 2 points. And the number of worsening problems that you're following up on can increase that number of complexity points for the number of diagnoses or treatment options pretty substantially. New problems are always weighted higher, like I previously mentioned, and they can be a new problem with no additional workup planned, or a new problem to the examiner where additional workup is needed in order to effectively treat the patient. All of those are weighted higher than your established problems and your self-limiting problems. So you would tally these up based on the encounter and total it up at the bottom to give you your final result. The data reviewed, if you're reviewing labs or ordering lab tests, you only get 1 point for those. So you can review 1,000 labs if you want to, or order 1,000 labs if you want to, but regardless, you're only getting 1 point for that. So just be aware of that. I see a lot of times providers will throw pages and pages of labs, but they're still only getting 1 point when it comes to medical decision-making for determining the level of service. So only report those that are clinically necessary for the patient that you're seeing and relative to the disease state is my advice. The other stuff's important, but only important for the condition that you're managing today. You can review old and order tests and get an additional point. In terms of the X-rays or examinations, those are separated out from labs. You can discuss tests with a performing physician. So if someone if a provider in your clinic ordered a test and you want to discuss that, you could discuss that conversation and summarize it within your note and get an additional point. Most of the time, we usually end up having 1 or 2 points for data and the amount of data or complexity reviewed in most situations as pharmacists and even providers for that matter. And these points would be totaled up in the bottom and you would categorize it appropriately. Now, risk is a good one. I want you to focus on presenting problems and management options when we talk about risk. Risk, you always choose the highest risks. You assess each category. So you may have a person who is at moderate risk, having 2 stable chronic problems, or having a mild exacerbation with 1 problem, which would be moderate risk. The amount of ordered tests that you performed, which is usually in most cases minimum because you're usually doing some type of point of care testing, which requires venipuncture. And then your management options. So if it's a low risk patient, you're talking OTC drugs, IV fluids, no real risk factors there that you're worried about. With a moderate risks, you will notice on there prescription drug therapy. So most of the time when we're working under a collaborative practice agreements, we are increasing medications or ordering new medications, and that would automatically put you at a moderate risk in terms of your management options. High risks has to do with that clozapine case example. That's an example where a medication that requires intense monitoring would be appropriate for you to categorize it. So if it's an oncology drug or a drug that you wouldn't prescribe unless you got a lab result, think about it like that. There's not a lot of that going on in practice, but it is common. Certainly with clozapine monitoring, even in epileptic drug modeling, you see pharmacists doing that. So let's go through an example UTI case and kind of bring it all together for you. So in this case, we have a patient coming in who's complaining of frequent and painful urination. It's a 36-year-old female. They're presenting today to establish care with me for the evaluation of gross hematuria. Patient reports 2 episodes of gross hematuria over the last month, also reports significant bladder discomfort, mild dysuria, symptoms persisted for 5 to 7 days, reports mild relief using OTC over-the-counter medications. She was treated for an uncomplicated UTI last year and was treated successfully with Bactrim. Today, she denies flank pain, fever, nausea, or vomiting. She admits to urinary symptoms, particularly frequency, nocturia, and a sense of incomplete emptying, and has a bit decreased force of strain. She has to strain hard. She currently takes Sprintec, but does not take any other prescriptions or OTC or herbal products. She has no known drug allergies. So this is when we're codifying history, HPI, you would already have had 1, 2, 3, 4, 5, and then some, in terms of the amount of history we obtain. You would already be in a very extended history at this point. And the additional associated signs and symptoms, patient denies flank pain, those could be used to qualify for review of systems if you hadn't already obtained those. But that's pretty much where a coder or a reviewer like myself would stop. Once we get over 5, we're pretty confident that you're going to be in an extended history or comprehensive history category. The past medical history is dysmenorrhea. So we took the family history. She has no family urologic history. She denies any tobacco use. Her review of symptoms, she's significant for urinary frequency, urinary urgency, painful urination, and nocturia. She denies fever or flank pain. All other systems are negative. So our review of systems would be 6, and our past family and social history would be 1 today. On our physical exam, we took blood pressure, pulse, respiratory rate. So we got 3 out of the 6, so we're able to bullet 1 point for constitution. We have a bulleted point for appearance. This patient, she seems reasonably healthy, though she's not in acute stress. Her mood and affect are appropriate. Her respiratory effort is unlabored, at rest, probably I should say. Cardiovascular, regular rate and rhythm peripherally. Musculoskeletal, she's negative for CV tenderness. So we have 6 bullets of extended problem focused. We ordered a point of care urinalysis and it was positive for nitrates and trace white blood cells. So our plan for this patient is that they'll start Bactrim twice daily for 3 days. The patient was counseled on a new medication and when the additional follow-up would be needed should her symptoms worsen or do not improve within 3 days. The total time that we spent with this patient was 30 minutes. So if we're going back through our steps for evaluating what level of service we're using, is this a new or an established patient? Well, this is a new patient that was clearly detailed out within the first line of our history, and that's where a provider needs to put that. This is a new patient establishing with me, or this is a patient I'm following up on for a certain disease state. And then, so we're going to be choosing our 99201 and 99205 CPT codes. So we know that we need to have 3 out of the 3 core components required, and they all must align or the lowest one selected in order for us to choose the correct CPT code. So now we know we spent 30 minutes with a patient. So we're looking at this could potentially be a 99203, so based on time. So let's go back and see if our documentation supports that. So let's look at our history and present illness. We had 4 points of HPMI, and our review of system, we bulleted out 6 points. So we're in extended for both the HPI and review of systems. We had 1 pertinent past family and social history. So we would be at a detailed level of service based on our history. And because this is a new patient and not an established patient, it would be a 3. We would be thinking this would probably be a 3 based on history. Now let's look at our physical exam. So for our physical exam, we had 6 bulleted points. So we're at an expanded problem-focused physical exam. And for the number of diagnosis or our medical decision-making, we have a new problem that's new to us, and we're not doing any additional workup. So that would be a maximum of 1. So we would have 3 points in total for our diagnosis and treatment options. We only ordered a UA, so we get 1 point for labs. And for our risk, we have a pretty, acute, uncomplicated illness that's occurring, not something that's chronic. We did a basic, diagnosis procedure ordered by ordering the UA. So we got a minimal amount for the number of procedures ordered. But our management options, we prescribed a drug, which gets us into a moderate degree. So for risk, you always choose the highest of the 3, which is a little bit different than what you would do with history, right? So risk is a little bit, you always choose the highest risk that you've attained in any of the 3 categories. So we're at a moderate risk. So based on our medical decision-making, we had our history, which was comprehensive, but we had a expanded problem-focused physical exam because we didn't exceed 11 bullet points. We only had 6. And from our medical decision-making, we know that we are in a low to moderate. Actually, our medical decision-making was in a moderate medical decision-making because we had to backfill that to a 2. So the most appropriate code that we would put, since physical exam and medical decision-making were aligning, we would backfill the history back, and we would actually choose a 99202 as the most appropriate code for medical decision-making, even though we spent 30 minutes with the patient. Now, if we had documented more thoroughly the counseling and coordination of care and education within the chart note, then we probably would be able to get away with billing on time, but that has to be clearly documented on what you documented on and how you, and a lot more detail needs to be provided. So this is kind of the difference between whether or not you document in detail what you counseled on and make sure you clarified your points. Sometimes you might be able to get a higher level of service with time, but more often than not, you'll find that you're getting more higher level of service based on medical decision-making than you would be on time 9 times out of 10. Would you agree with that, Zach?
Absolutely.
So just reviewing the final level billing summary. Step 1, identify this is a new or established patient. Step 2, determine the level of service based off time. Step 3, backfill and assess whether your documentation supports that time, and then choose your final code. So if it was time, it would be a 99203, but as we know from a medical decision-making standpoint, it ended up being a 99202. All right, and that was a good review of the basic components of evaluation and management. We'll be going over this in a lot more detail during our lab on Monday. So please come prepared with questions and bringing a few example cases, and Zach and I will be walking you through a couple of our example cases and making sure that this is solidified in your brain for the exam. But for the remainder of the lecture, Zach and I want to discuss other services that pharmacists are submitting to the medical benefit and receiving reimbursement for. The vast majority of other services are usually billed instant to in states that don't have provider status or when billing Medicaid. You don't need to know what instant to is, but feel free to look it up if you're curious. But it's just basically the ability for a provider to refer a patient to you and for you to provide the service, but bill under the provider's national provider ID number, and then the provider receives payment for your work. very common practice with physicians and other mid-level practitioners, and is an option for pharmacists to receive additional reimbursement under the medical benefit in states that don't have provider status. So let's move on to some of the services. I think one of the more common services we see, especially out east, is annual wellness visits. And these are a Medicare-specific code. They were established in the Affordable Care Act in January 1st, 2011. And patients are eligible to have these done within the first 12 months of them being enrolled into a plan. They may be provided by a physician or other licensed practitioner working under direct supervision of the physician, and that's why I wanted to introduce that concept of Incident 2. And they pay out pretty good and have a pretty hard relative value unit. And providers generally, these take a lot of time, and they're a pretty in-depth screening and assessment, but not the assessment and examination that we talk about with evaluation management. There's actually no physical assessment that's required. Isn't that correct, Zach?
That's correct with the annual Medicare wellness visit and the both the first and the follow-up wellness visits. The Welcome to Medicare IPI visit is actually an introductory physical examination and a preventative care visit. So that first Welcome to Medicare visit encompasses a comprehensive physical exam as well as the components that are generally rendered then in each subsequent annual Medicare wellness visit after that, which does not contain any physical examination.
Now, pharmacists aren't typically billing the Welcome to Medicare annual wellness visit, though, right? The Medicare has rules around that's usually only done by the physician or a nurse practitioner or a physician assistant.
Generally correct. They could be a component of the team conducting the visit and doing some of perhaps the medication review component or some of the preventative counseling, but just workflow wise, since the provider already has to have a more detailed examination in that and more time invested in it. Generally, it's the Medicare recognized provider performing the whole IPI. And then where pharmacists usually take a role in wellness visits is conducting the majority of or the entirety of the first and ongoing subsequent annual wellness visits, with the Medicare provider coming in to verify the plan and determine if there are any other questions the patient may have to document their agreement with the plan.
And from a health plan's perspective, we actually encourage pharmacists to do annual wellness visits within our network at Care Oregon. The pharmacist provided Medicare annual wellness visits are considered best practice and the standard of excellence when doing an annual wellness visit. We have an entire HEDIS nurses that review these annually, and they are always very excited to see the pharmacists doing this because they do such a good job, particularly around the medication management and the thorough documentation of examinations and screenings that are appropriate. And it's also a very good opportunity to close crucial gaps in care for payers to help increase alternate payment model reimbursements for your clinic site and for the payer. Zach, are you doing this very often in your clinic systems?
We have historically done it. We're not doing a lot of it right now, primarily because we don't have a huge Medicare population in our specific clinic setting. I know a lot of other clinics in our area, their pharmacists do a lot of this. I have one pharmacist in particular who actually created our protocol for this and is very interested in and has a population that has a higher percentage of elderly individuals. So this is perfect for her work. So it's not something we do every day, just given the workflow around it being a longer visit and being a little bit different than the traditional provision of a problem-based encounter.
No, I usually categorize this service, annual wellness visits, as it's kind of an unlimited access. You pretty much only do it once a year. So it's not something you can incorporate that in your practice, but probably not something you want to build your home on, right?
Exactly.
Okay. Now this slide here is just kind of going over the components of the types of screenings and assessments that are typically done within the annual wellness visits. We don't expect you to know these, but they're there for you to review. Now, transitions of care management services is a big deal coming next year for CMS, for both Medicaid, Medicare, and probably a lot of the commercial payers too, when in terms of major heavily weighted quality metrics that are hard to meet Transitions of Care Services, or TCMs, have billable codes. They pay out pretty well. They're another team-based code, like Zach was talking about, and they can be provided by a qualified physician or other qualified healthcare practitioners. And even some states' pharmacists are engaging in this activity, but not to the degree that we would like in Oregon, at least within my network. Now, Zach, what do you think the biggest barriers are for transitions of care management by a pharmacist? Because in my opinion, it's clearly well within the pharmacist's scope of practice, but we don't see a lot of pharmacists do it largely. They may play a role in that with the medication review that has to be done prior to the face-to-face visit, but I don't see a lot of pharmacists actually rendering the service.
Right, and that problem, or the whole barrier there, is the recognition by Medicare, in that this is a Medicare-driven code, so this came out of the Affordable Care Act, and additionally, it is not a code that all health plans, so all commercial plans don't cover this, and initially not all Medicaid plans covered this as well, so this was a Medicare-specific plan. And while you could, as a pharmacist, be a component of the work, there are two components to a TCM code. There's an initial outreach and communication to the patient prior to the actual face-to-face encounter, which is generally where pharmacists have been involved in doing a telephonic or face-to-face medication reconciliation after discharge. But because the face-to-face component has to be billed by a Medicare recognized provider, and because they just came out of a hospital setting, an inpatient setting, you don't meet criteria for incident to billing, because incident to billing has to be based off of an established care plan from someone that you are in the same practice of. So unless you're in the same practice as the hospitalist provider and they've directly referred to the pharmacist and established exactly the care plan to be followed, you don't meet those criteria. Now, under Medicaid plans that do cover this service, a pharmacist who is a Medicaid provider in the state can provide the whole spectrum of transitional care management.
Okay. Yeah, and one of the interesting things about transitions of care codes is that within the actual ruling on these codes, when this was created, it specifically excludes MTM codes as reimbursable codes for a patient who has discharged within 30 days after discharge. So if you build an MTM code during the same calendar month as the transition of care code, that we wouldn't be able to pay that, because that's supposed to be a component of that. Now, in some plans, with Medicaid and with provider status for Medicaid, what we recognize for providers, pharmacists, healthcare providers, do you think that would be more likely to be able to build this plan, especially since the big movement in healthcare is not having the hospitals do this, but having the care plan developed by the primary care site using the discharge plan from the hospitalist as part of the transition to care service?
That makes sense. And so the movement really being this, because medication reconciliation is a component of the code, it makes sense that you wouldn't be able to bill an MTM service code in the same period that this code is covering.
Yeah. The other codes that I think are gaining a lot more popularity are chronic care management codes. Now, I have very little familiar with these codes, but these codes have to do with creating a care plan. They're also a team-based code. They're covered on both Medicare and Medicaid, and probably some commercials now. Zach, can you speak to that? Are more commercial plans picking up chronic care management codes?
Not that I've seen yet, but at the same time, I know of a couple practices that have utilized pharmacists to implement this. Generally, practices without pharmacists, I haven't seen of any that have implemented this without them. Even though it's not specifically called out, it seems to be a little bit more pharmacist-driven or nurse case management, and generally the two combined. But there are specific criteria for if a patient is eligible for this. And again, it's generally with one subpopulation of payers, so it is primarily your Medicare patients. And the reason there hasn't been a big uptick on this is because this is tracking multiple interventions by non-physician or non-physician or non-provider care team members, and over a 1-month period. And this here is basically to capture all of the work that a clinic puts in to manage a patient with a chronic disease that will persist for life, or at least 12 months, and may have significant impact as far as the risk of death or exacerbation to the patient. So what that really looks like is someone with, end-stage heart failure or COPD who is frequently going back to the hospital. This is to capture all of the work done by perhaps social workers, medical assistants, care team nurses, and pharmacists in outreaching telephonically to the patient to check in on their adherence to a care plan, or perhaps even the changes that occurred from a pulmonary rehab visit, and just following that patient on an ongoing period. One of the big limiting factors beyond just tracking that time and being able to submit the code consistently month to month by the provider after they've reviewed and compiled that documentation is the fact that a patient still has a copay with this under Medicare. So there is cost sharing that's associated with it, and you have to have the patient in the clinic in front of you and get actual signed consent from them that you will be able to provide this service.
Yeah, and the requirements are pretty rigorous too. Having had 24-hour access to a provider, those types of things can really be a disadvantage for smaller clinic systems. And I think, they're becoming more and more of a focus. This is certainly a service that pharmacists can provide. In fact, our regional QIO lists pharmacists as the potential providers for CCM. Which is rather confusing to me, because when I think about how intense this type of service is, it seems to be a lot more clinically intensive than a transition to care service in my mind when I think about the work that goes into assessing, monitoring, and updating a care plan. But for those clinics who can pull this off and are using pharmacists, this is something that you can bill reliably every month, as long as the patient has consented to it and you meet the requirements. There's a complexity-based component to this, much like the PCMs in terms of their reimbursement. But one other point is, again, one of the excluded codes when billing CCM is that within a calendar month, you can't bill medication therapy management codes for the same patient either. Now, I don't believe that applies to evaluation and management. Is that your understanding as well, Zach?
Correct. It doesn't apply to evaluation and management codes because they can still have any problem-based visit that may be indicated during that time period. And the nice thing is, I'm not sure how it makes more of an impact in your Medicaid patients where pharmacists can drop MTM codes. But as far as Medicare patients, when we're talking about straight Medicare, MTM codes go through Part D benefit and are not billed to the medical benefit of Medicare. And we often talk about all the work that we're doing and providing for free as it is, that if we simply were tracking, we'd be able to recover with these codes. So it is something that a lot of practices are looking at right now to start recovering some reimbursement for services that they're already providing or that pharmacists have been providing for a long time.
Yeah, you're absolutely right about that. Now, the other big category, I think annual wellness falls under this bucket, is preventative health services. And that's kind of where there's a lot of different preventative health services out there. There's many, many codes. We've included a list of CMS's comprehensive list, which walks through each of the components of the preventative health services that are approved by CMS and what documentation requirements are required and everything. We don't expect any of you to know that at all for the exam, but just be aware preventative health services is a very upstreamist view to how healthcare is starting to deal with our chronic disease population. And it doesn't require it doesn't require referral in most cases. A lot of these preventative services are self-identified, like smoking cessation, and can be and are well suited, actually, in my opinion, for community pharmacy. Even in acute care clinics that have clinical pharmacy access, it seems like it'd be a logical next step for community pharmacy to move into preventative medicine, in addition to the prescribing and diagnosing of acute care needs. And then last but not least is one of the new ones, remote warfarin monitoring. That was new in 2018. It replaced the anticoagulation codes 99363 and 99364. These are really unique codes and can be hugely beneficial to our friends who are working in warfarin clinics and doing a lot of warfarin management, because they apply specifically to warfarin and INR monitoring that's done telephonically and remotely. So it allows you to train a patient on how to use and self-monitor INR machine which you can drop a code for. You get one. You get to drop that once per year. Is how our benefit is set up. But in addition to that, when you're calling the patient and monitoring their INR over time, you can use 99373 as a telephonic code. It doesn't pay very much though, and that probably has to do with the limited intensity of warfarin management. Even though there could be a lot of complications associated with it, it generally is a lower level of complexity in terms of the service. Even when billed face-to-face as an evaluation management, it's pretty hard to go above a 2 in my experience. Zach, are you using those, or anything you think we're missing in terms of how these codes are used in your practice?
We're not using them in our practice, and I think you've covered them pretty well. The majority of patients we're managing in our practice have been transitioned or started on NOACs, and there's pretty available and accessible warfarin and anti-coag clinics in our community network that actually have pharmacists that are outside of our entity managing warfarin if we have patients who are on it.
So how we kind of, Zach and I, think about the development and intensity of reimbursement for clinical services kind of follows this diagram here. When you have a low touch, episodic, limited access, low intensity care, like that's your preventative medicine, your immunizations, your laboratory services, your Part D MTM, right? You don't get a consistent access to patients doing these services. They're episodic and acute, low touch, right? Continuous, more medium touch or limited or high intensity services are going to be your chronic care management, your warfarin monitoring, and even your transitions of care in some degree. But again, they're low access, high intensity. So you might not have a consistent supply of these throughout the year, other than chronic care management, with that exception, I'll make, right, Zach? Those can be billed monthly. Then you have your more autonomous, high touch, high access, high intensity services. Some of your MTMs or telephonic codes or telemedicine codes is really what that's supposed to represent there. And I would actually move chronic care management over there now, just because when we originally made this slide, there was only 2 codes for chronic care management, and it was pretty straightforward. Now we have a lot of different codes that help augment that chronic care management to make it a lot more intensive a service, a lot more clarity on how to use them over the last couple of years. And then the more autonomous, high touch, high access services are going to be your evaluation management, telemedicine type services, where you're owning care as a provider. You're seeing patients and doing chronic disease state management. And that's kind of where I think, and I think most of the time we see more of the advanced practice sites focusing most of their efforts around chronic disease state management with their clinical pharmacists. I know for a fact that Zach's really built his team up around that. Isn't that right, Zach?
Absolutely.
Okay, guys, this has been a really informative second lecture. I know it's a long haul and there's a lot of information, so I would encourage the students to listen to this a couple of times if you can, but at least once. For the lab, you will need to come with your diabetes write-up from case studies. You had case 1 or part 1 and part 2. We want you to bring the part 2 write-up. You don't have to do anything with it. Just print it out and bring it with you, because we'll be going through an exercise where you're going to code and possibly even modify your notes so that you can bill for the service that you provided in that part 2. So I'll say that again. For all the P2 students, bring with you your diabetes part 2 case write-up. That's that insulin start that you did for that gentleman, and be prepared with a printed copy of it. I would also encourage you to bring your copies of these slide decks, which will be posted here with the videos. And with that, I'd like to thank Dr. Roscoe and Dr. Hibbard for their time and for donating their time here to help us understand the emerging and contemporary billing opportunities for pharmacists for non-dispensing services. And they will be on site. Dr. Roscoe will be in Pocatello, and Dr. Hibbard will be in Boise, and myself, Dr. Wadsworth, will be in Alaska, and we look forward to being with you at the lab. Thank you.